doesn't put in.
What I am saying is, somewhere in India, there is an SIC surgeon who charges 2 lakhs for SICs. So let's not go. We'll not do that.
So that's not Narayan Netral.
Yeah,
It's not like.
Yeah.
I think they charge that much for their gene therapy to inject lysyl oxidase into the cornea. Anyways, dear friends, the nucleus has been delivered and the IOL is placed. Now, this is a mid-dilated pupil, and here we do a rhexis behind the iris. Slightly tricky procedure, but this is something which we can do with practice. So the rhexis is initiated and it is taken behind the iris. This is actually not blind. This is the third eye of the surgeon visualizing the rhexis. So the rhexis is done. Yes. And we are checking the size of the rhexis by retracting the iris. And then of course the surgery is done and the IOL is placed in the back. Now this is a non-dilating pupil. There is severe pseudo-exfoliation and it is a dense brown cataract. In this situation, you can see the multiple side-port incisions which were put, and the incision is made through the conjunctiva. Anyways, so we are going to use 5 iris hooks. To convert the pupil into a pentagon. In this case, we have an option. We can do a capsular rhexis or we can do a can opener capsulotomy. What would the audience prefer? Sir? It is always better to be safe than to be sorry. That is the correct answer. So we do the can opener capsular rhexis. Capsulotomy, yeah. Deliver the nucleus out, and then we place a 3-piece IOL against the sulcus in this case. Please remember, when you do a can opener capsulotomy, please do not attempt to put the IOL in the bag. However beautiful and enticing the can opener capsulotomy may appear to you. Therefore, the take-home message is capsular rhexis is definitely an ideal choice, but not always the best choice in difficult situations. Always choose the method of capsulotomy correctly to avoid complications, and manual small incision cataract surgery allows a lot of freedom for us during the steps of the surgery. Unlike phacoemulsification, which is comparatively limited in its many choices. I am not an advocate of SICS, but I only wish to understate the fact that the SICS is also a relevant surgery because it provides for a safe execution of cataract surgery and a safe implantation of an IOL and a safe insurance to good vision for the patient. Thank you very much, my dear friends.
Thank you very much, Dr. Sai, for insisting that safety we should consider before all these tendency to do only capsular rhexis and all. So when we are faced with this kind of very difficult ones, very bad ones, be sure which is in your